Welcome everyone to our weekly Biomedical Informatics Research Conference on this gorgeous day, and we're all behind our screens and inside our homes, or maybe some people are outside. But anyways, it gives me great pleasure to introduce an outside speaker, someone from outside OHSU, and maybe one silver lining of the pandemic is that we've been able to have a few more people than we might ordinarily have, and they don't have to travel, even though most people would probably prefer to be in Portland on our sunny 80-degree day today. But anyways, I'm happy to introduce Dr. Sarah Collins Rossetti, who is an assistant professor of biomedical informatics and nursing at Columbia University. You can see that she has both an RN and PhD. Her research is focused on identifying and intervening on patient risk or harm by applying computational tools to mine and extract value from EHR data. She also is an experienced critical care nurse and received her PhD in nursing from Columbia, and then did a postdoctoral fellowship in informatics also at Columbia. She has become involved in this interesting project that we've invited her to talk about today. And I'm sure that most of you know this is a real critical issue that we face now in the field and in healthcare of documentation burden. So she's going to talk to us about an initiative that a number of institutions, including FAMIA and NLM, are involved with to reduce documentation burden. Also would like to point out that Sarah was selected as a 2019 recipient of the Presidential Early Career Award for Scientists and Engineers, or PCASE, which is the highest honor bestowed by the US government to outstanding scientists and engineers who are beginning their independent research careers and show exceptional promise for leadership in science and technology. So at this point, I will turn it over to Sarah. She will present her talk. As usual, you can type into the chat box, although she probably won't see it until the end of the talk. And then when she's done, she can answer questions from the chat, or people can feel free to unmute and ask the question verbally. So go ahead, Sarah.
Great. Thank you so much, Bill. It would be wonderful to be there in person, but this is just as good for this year. So yes, today I'm going to speak about this project on decreasing documentation burden. I'm going to talk about the NLM funded symposium that we had this winter. And then also at the end, I'll talk about some of my specific research that really relates to this problem too. Great. And so documentation burden has been recognized, increasingly recognized throughout our country. It's not solely a problem in our country. We've learned through the symposium we held there are issues, certainly internationally as well, but there is a major focus on it nationally, and that really does also relate to things such as our reimbursement models, that are particular to the US. And so the National Academy of Medicine has recognized the problem of documentation burden, specifically as it links to clinician burnout. And there are studies that have associated the two. The 21st Century Cures Act also does recognize burden in the way that that Congress actually required the Department of Health and Human Services to act on this problem. And so kind of in that realm, ONC has taken the lead in work to reduce documentation burden. They published their final report recently on strategy on reducing regulatory and administrative burden relating to the use of health IT and EHRs. And there's also the quadruple aim. So for many years, we had the triple aim, and which had to do with enhancing the patient experience, improving population health, and reducing costs. And the quadruple aim then includes improving the work life of the healthcare provider. And so this is just seen from many perspectives, as increasingly important. Some background on documentation burden. I actually didn't want to spend that much time during this talk talking about, essentially the literature review of it. Through the symposium that I'll talk about, we have a website up which actually has a really nice set of resources we've put together of, publications that that discuss documentation burden, peer-reviewed publications, and some others too. So you see those links here, and I'm happy to share these slides with you after as well. But just to kind of sum it up a little bit, we know that EHRs are essentially in their infancy, when we really think about where we were with meaningful use and where we are now. If we look at that timeline, for example, versus how long we were using paper records, it hasn't actually been that long. So when you reflect on it from that perspective, you can start to see there's much opportunity, and I'm sure many of you know, to increase the usability of our records, but other things too. There were workflow processes that were essentially just taken from the paper world and put into EHRs, and we still kind of struggle with those. And then, of course, there's the regulatory area and reimbursement area. And I'll talk kind of about those domains that we identified during our symposium, or I should say the framework we used, which identified those domains during our symposium. One piece of work to highlight comes from a PhD student in my lab, Amanda Moy, who did a systematic review of approaches to measure clinician documentation burden among physicians and nurses. And essentially, I just want to highlight this because I think it's important as I'm talking about what we learned during this NLM funded symposium that we put on. We have to always remember, if we want to actually make a change and a difference, we need to measure that difference, right? And so we need to be measuring that now if we want the change if we want to understand if we made a change in a year, 5 years, or 10 years. But really, there's a lack of standard and validated measures of clinician documentation burden. There are some core concepts that seem to be consistently measured. So effort that clinicians put in, and that can be looked at through a few different ways. Usage and workload in the EHR, logging into the EHR after hours and remotely, the number of administrative versus clinical tasks. You can look at cognitive workload. You can look at fragmentation of the workflow, and then the level in which patient interaction is kind of impacted. But again, there aren't consistent measures for each of those. And then time is the other major category. So looking at the average time spent in the record, the proportion of time spent on different activities, the timeliness of completion of the record, etc. And then we found 11 different units of analysis for time, for example. So there's some work to be done in how we measure it so that we can be more consistent and actually determine if we've improved. So this slide here highlights the symposium, which I've been referring to, which was titled 25x5 Symposium to Reduce Documentation Burden on US Clinicians by 75% by 2025. So we want to be at a level of 25% of what we're at now in the next 5 years. And again, we need to be able to measure in order to determine if we get there. So I just want to recognize my co-chair, Trent Rosenblum from Vanderbilt, and steering committee members that you see here. There's the link to our website as well. So please feel free to access that. All of the talks that were given during the symposium, which ran for 6 weeks in January, this past January and February, are up there, both the video as well as the PowerPoint. So it really is a nice resource, and I encourage you to look at it. The work from the symposium is ongoing, and I'll kind of talk about where we are with that, but I want to make that clear up front. So our goals were to create a meeting that engages a diverse group of key stakeholders and leaders focused on reducing documentation burden, to assess the likely potential for burden reduction within each category of documentation burden tasks, to establish approaches for immediate, short-term, and longer-term elimination of clinical documentation burden, and to develop a what we call 25x5 community of stakeholders and allies to keep momentum going and to support dissemination and change. We also want to maximize tequity of any proposed solutions, and this was very important to us, and was looked at through, we established a diversity, equity, and inclusion committee to look at this. So tequity is defined as the consideration, design, development, and implementation of technology solutions that promote, assure, and potentially enhance health equity. Our principles of engagement, these were kind of laying the groundwork as we started the symposium and bringing together a diverse group of stakeholders. So we wanted to make sure that solutions that were proposed, for example, leverage technology and existing data inputs were appropriate in order to do things such as reduce redocumentation of items already captured during other intake processes. That there should be no erosion of care standards, should maintain high quality, safety, value, efficiency, access to care throughout any proposed solutions, for example, to maximize clarity of proposed rules, to minimize misinterpretation by health systems and providers. And we found that there certainly can be a lot of confusion sometimes, especially in the regulatory domain. And that there should be no wholesale shifting of work from one clinician to another clinician, that we actually are seeking to eliminate unnecessary documentation altogether, rather than moving it from one type of healthcare provider to another type of healthcare provider. So just so you have a sense of what we actually did, I said there were 6 sessions. They were held on Friday afternoons for 2 hours each. And in the first one, we had, introductions, but we were focused on talking about current challenges related to what we document. In the second session, current challenges related to how we document. The third session, we had some exemplars presenting and talking about their key successes and what we could learn from them. The fourth session was talking about emerging and future innovations as solutions, and that included a panel from the vendor industry community. The fifth session was our first kind of reactor and prioritization session. So we started our breakout sessions during this week, and then we continued breakout sessions in session 6, as well as had a nice plenary presentation from Christine Sinsky. We had over 300 participants joining, across the weeks, which was really just wonderful to see. And I think certainly the virtual format actually ended up being really great to allow more participation than certainly would have occurred in person. So just quickly to highlight some of the specific speakers, this is from our first week. So a panel on policy and reimbursement issues, and a panel on clinical practice and documentation issues. We also had other panels focus on, for instance, current challenges around how we document, such as workflow and usability issues. And, like I said, all the resources are online, so I don't want to just rehash, what they all said, because we have more content to talk about actually in terms of the outputs of the symposium. But to highlight some key points here, and you'll see this slide is borrowed from Kevin Johnson, where actually we are presenting a panel next week at the FAMIA Clinical Informatics Conference, and so this slide is from that deck. But there was some presentations. Andy Gettinger from ONC talked about 21st century cures and some of the changes there. Mary Green from CMS talked about prior authorization, how it should be simplified and eliminated, and that work is underway looking at documentation requirements and the importance of getting providers clear guidance about requirements. There was also talking about, the need to measure change and learn from that with transparency, for frontline, providers and builders, presumably. And then, it was noted the importance of any work that we do, really looking at it from the perspective of the environmental and social impact as well, and kind of this process re-engineering. It was mentioned quite a few times throughout the symposium in the past year. Lots of changes have been made at various sites to the documentation, electronic health record configurations that exist. For example, can we learn from that? What was done to streamline things? Just a few more points to highlight here. The need to address usability challenges of duplicate documentation, issues around siloed notes and readability of the output, better use of data generated through Internet of Things, just emerging technologies, patient-reported outcomes and health information exchange, that that workflow integration is incredibly important, and attention to, who, what, when, where, why, and how they are documenting. There was a lot of talk about clicks and balancing that with the need for structured data, and that there are some frameworks that can be used to help address, the volume of clicks that we require. And I'll talk a little bit about some exemplars that had success in that area. And then there was a pretty strong focus throughout on this notion of teams, but really expanding kind of our notion of teams, to make them even bigger and better, if you will, but really having our documentation reflect that. So while we may have care teams, we don't have shared team documentation for the most part, across most areas. And looking at more complex models that really could benefit team-based care, but then benefit the documentation in order to reduce redundancy across members of the care team having to document the same thing over and over again. New capabilities through speech recognition was a focus area as well. And then, of course, copy and paste came up, noting that that's a way that there can be some consistency in the documentation, but it can certainly propagate misinformation. It increases note load, and a variety of usability and workarounds related to that too. So it's not necessarily a good thing. We also had an amazing chat. So we held the symposium on Zoom, and the chat log was just phenomenal. And the attendees, they were experts in our field and related fields, just within healthcare in general. So it was really an incredible group of people that were very actively writing in the chat. And so I call it out specifically, not because I have particular content from the chat to share with you, but because we've actually posted them. We de-identified them and we've posted them on our website. So they're available. Our team is starting to look at how we can use some text mining of it to analyze the chat, because it's really valuable, and we want to do that. We're just starting it on that, but I think it'll be exciting to see what emerges from it. To highlight, our focus on diversity, equity, inclusion, and what that really means when you talk about documentation burden. And so Ken Cato led this talk and led this committee. But it's to recognize, where our documentation comes from. And so as we talk about needing to change the documentation, we need to reflect kind of on where it comes from and the issues, some of the issues driving it, and some of the issues of what's missing from it. because we need to think about it too when we talk about reducing documentation burden. Might not always just be taking things out of the record, but that culture, organizations, people, technology all impact the structure of the documentation that we have. When we think about the process of documentation, we have to raise the question of, well, who's defining the goals of documentation? And I see some of these questions really starting to kind of broaden, perhaps with the new information blocking rules coming out, and patients having more easy access to their chart too, that we might look at these questions more and differently. And then outcomes, that information is filtered through systems and processes. And so what we're recording is just a snapshot of really the care that occurs, and to just make sure to look at documentation through these lenses to make sure that we can, that we're always considering, how our documentation structures, our processes impact health equity. To highlight the exemplars, these were some of our exemplars. So one from Hong Kong, one from the UK, one from the Da Vinci Project from HL7, and then another from HCA Healthcare System, and then another from University of Colorado, also from Vanderbilt, and then from Penn, which was actually a company founded called Caroline, and then also from the Cancer Resource Center of the Desert, which talked about including diversity, equity, and inclusion approaches. So I don't have time to highlight all the exemplars, and I don't think that would be the most valuable use of the time. They are online, but just to reiterate some main points, this is just a slide from one exemplar, and I like this slide because it shows just how much extra documentation is there in our records that you can get rid of. And I think it's important to reflect on that. So 496 flow sheet rows eliminated from UC Health EHR when they really started in on this work. They then had 18 fewer minutes in flow sheets for nurses, and this work was focused on nursing. So that equated to 64,000 RN hours, worth over 2.8 million annually, and they equated that to 360 million fewer clicks a year. So obviously, context matters, what's your denominator here in all of that, but the numbers are big, and it just points to the fact that there's a lot that can be done. And so if this is what one site could do, and they're using, they were using Epic, a vendor that many sites use, that there's room, there's room for improvement at perhaps a lot of other sites with the overbuild that we know occurs. So some takeaways from the exemplars. Exemplars are doing excellent work. There are great tangible results. Unfortunately, it seems that there's a lack of broad learning from what they're doing at these, individual sites, lack of dissemination of it and spread to other providers and health systems. That's really not happening. You don't really see as much of that written up in the peer-reviewed literature, for example. And so, we think that there's a lot of opportunity to expand that dissemination, whether it is through peer-reviewed literature or otherwise, just that dissemination to happen and that spread to happen. And we think that partnering certainly with vendors and policy advocacy groups should happen as well. The international groups that presented, while they don't have the same reimbursement regulatory constraints, they still experience burden and are focused on decreasing the size of their EHR content notes. So that speaks to the fact that all of our documentation burden probably isn't driven by just reimbursement and regulatory demands as well. And we pretty much know that, but I think that kind of helps drive the point home as well. So one thing that we also did before the symposium started, and then we shared these results at the symposium, everyone knows this was quite a unique year. with the COVID-19 pandemic. Our hospitals were extremely burdened with, limited resources and the acuity of patients and sheer number of patients, particularly in the ICUs. And we know that nurses, physicians, and other clinicians and other staff at the hospital were really overworked at various points. So a lot of sites, as well as some laws, state laws and otherwise, said, okay, we're going to decrease the regulations on your documentation. And for the most part, those may have been decreased, except in the area of medications. But so we surveyed. We did a national survey of like, what changes did you make locally to your system? Now, the survey was sent out kind of in a snowball sampling approach, right? So we used professional listservs. We asked clinicians and informaticians and so forth to forward it to their respective groups. So we couldn't calculate a sample size because of that, but we wanted to increase, the breadth of responses that we got. So that seemed appropriate. But we got 351 responses. So our findings were that the majority of sites experienced a telehealth expansion. I think this is already pretty well known. And they preferred, in the context of documentation burden, they preferred that remain permanent. Over 2/3 experienced telehealth coding changes for E&M. The majority of the sites supported additional documentation strategies associated with EHR usability, and this included eliminating alerts, for example, or optimizing the login process, as well as data entry. So things such as documenting only pertinent positives, as opposed to, the entire, system review. And that there's less support, though, for shifting work to ancillary staff. So more support for changing the actual EHR configuration than the shifting of documentation. But there were also variability in perceptions and experience of documentation burden. So some people preferred the charting by exception that might have been implemented, and others did not in the context of documentation burden. So there were pros and cons, throughout. So then switching gears a little to our output and findings from the symposium. So I had said how during our final 2 weeks, we had breakout sessions. And we use the ANIA framework, the American Nursing Informatics Association, that is put forward this framework focused on documentation burden, and they outlined 6 domains of burden. So reimbursement, regulatory, quality, usability, interoperability, and this last one called self-imposed. So essentially, especially for clinicians or those that work with EHR systems out there, we've done it to ourselves, right? We overbuilt that system, even though the regulations or reimbursement, didn't require it, for example. And so that was our 6th domain. So we held breakout sessions that fell within each of these domains. And so we had over 100 participants in the breakout sessions. We had 19 breakout groups. There were just, some breakout groups that repeated across domains so that we could have a Zoom appropriate number per group. So we had a lot of data that generated from this. So now talking about our methods to actually analyze that data post the symposium. So we identified 82 action items. So I should say too, that the breakout groups were charged with identifying action items in their domain that would help to reduce documentation burden. From the content generated, there were 82 action items, and these mapped to 4 different themes, which we identified: accountability, evidence matters, education and training, and innovation of technology. And then we also mapped these, kind of orthogonally to 3 stakeholder groups: provider and health system. So the stakeholder groups were intended to be specific calls to action. So provider and health system calls to action, vendor calls to action, and policy advocacy calls to action. So just a little breakdown here of the themes around accountability. There was the notion not to work in silos, that we need clarity of roles and cohesive understanding of requirements among agencies and stakeholders, that evidence matters, that we need evidence-based practice informing measures. This came across very strongly across several different breakout groups across the domains that we have, for instance, regulations from accrediting agencies that there's not clear evidence behind those regulations, and it can be quite frustrating at the health system level in terms of trying to comply with them while trying to maintain, a record that that supports quality care. And so the need to generate evidence around that and also get clinician input. That there's a need for education and training, so documentation requirements and standards are needed. There's a need for brevity and clarity training for new clinicians, so how to be concise and how to appropriately be concise in your notes, for example, as opposed to copy and paste. And to focus on quality of the content in your notes over quantity. Also to incentivize training were some key points there. And then innovation of technology. So we need to start applying new technology that is available, voice recognition, other types of AI and platforms, as well as increasing interoperability, because that's also seen as a path to reducing redocumentation of information in our records, just leading to information overload, which is also a form of burden. So then those calls to action that I talked about that we map to those three stakeholder groups. So for providers and health systems, it was noted that within the themes of accountability and evidence, they should establish guiding principles for adding documentation to the EHR with multidisciplinary collaboration led by clinician experts. So it really should be clinician led, and generate evidence for reduced documentation impact on risk compliance and removing documentation that isn't positively impactful. In terms of education and training, they should develop and host a national roadshow, on the education that can occur directed towards professional clinicians and clinicians in training. And that particularly for med students and residents, universities and health centers should train on brevity in addition to completeness. Around technical innovations to expect or support real-time information retrieval, this came through a few times strongly in the breakout groups, that if you can in more real time get that information within the EHR, that it's easier to access, then you're less likely to redundantly document it. And then to implement interdisciplinary notes and team-based documentation. And that was a theme right from the start of the symposium. That vendors should, around accountability and evidence, promote an ecosystem of interoperable systems to allow for complementary technology beyond a single EHR vendor. Develop metrics to review and grade a user's documentation based on length, efficiency, redundancy, and provide ongoing user feedback and peer benchmarking. Related to education and training, to package the best training practices into toolkits to promote users' workflow, revisioning, and best practices. To plan recognition programs and publicize exemplars to incentivize the sharing of documentation burden reduction success stories. And around technical innovation to create simplistic EHR views to see that new clinical data has been reviewed, for example, and then bookmarked for that user and documented as reviewed by that user in the EHR, so that they don't need to go and manually document that they reviewed information, but that metadata, for example, is recording it and that's sufficient. Also to implement personalized CDS with AI to drive user-specific workflow and care recommendations. Around policy and advocacy, to urge NIH, that includes NLM and PCORI, HRQ, and OMC, to fund research related to capturing all coding information without coding, meaning billing information, without engaging any clinician time. So approaches to doing this payers to clarify and unify rules, develop data handoff handshakes, create prior authorization call centers, and assume responsibility for code validation. Related to education and training to select best of breed and implement systems throughout the healthcare system through a mixture of public and private funding. And then in terms of technical innovation, to develop technology to reliably and accurately create reimbursement and payment data for all care settings without clinician engagement, using different, there was a talk of using different AV, audiovisual components in care settings to capture all information relevant to coding and note generation, for example. So some key takeaway points from the symposium at the point where we are now. We brought together over 300 stakeholders. There were presentations from 33 individuals that represented a variety of different professional organizations and expertise. Documentation burden has numerous contributing factors. So really high level summary of some findings. Work to date has untangled some contributors to burden. We've presented several action-oriented next steps. We found exemplars from other industries and clinical settings. And the next steps will involve working with providers, health systems, health IT vendors, and national policy advocacy groups. Some specifics around that. I talked about how we have all those resources up on the website. We're currently doing many national report outs, including seminars such as this, which is great. It's great to present, to groups such as you who really include, a lot of people on the ground doing work in this area. We're developing our reports right now and creating a network of allies, through some of these dissemination activities and conversations. And then there is a need, we recognize this, and this is what we're working to try to promote, is to convene key stakeholders from the community to mobilize strategies nationally. So really to have, for instance, National Academy of Medicine, CMS, ONC, AMA, ANA, begin to have their strong working groups that move this initiative forward. So shifting gears a little bit here for the last few minutes, I'm going to talk about some of the research that I've done and collaborated with people on to begin to quantify and measure burden. And I say begin because I think we really are beginning. I talked about the scoping review that a student of mine did, finding that there really is a lack of standard ways to measure burden. There have been plenty of great papers, but lack of standard ways to measure burden. So we're looking at different approaches ourselves, but with the vision, and we're not quite there, but with the vision of how do these come together in a framework that can really drive this work forward and begin to standardize it. But I do like to start with this slide. This is from work several years ago, but it just it kind of reiterates to me every time I look at it, like why we're doing this again. And that when you think about the problem of documentation burden, you really kind of have to look at it through a number of different angles. So we talk about measurement, but let's take a step back and look at what's really in our systems at the same time. So we looked at the clinical decision support that was available for nurses. And this was in a vendor-based EHR. And unfortunately, a lot of the clinical decision support was supporting documentation. So it was supporting, a reminder to document your plan of care, a reminder to document this compliance measure and this task list item, and that you have missing required documentation over here, and your patient education documentation has to be done. So when we start to see that, it's probably a symptom of, you know, a poor configuration of the record, poor, you know, poor ways that we do or don't at all support workflow and usability. And so if we look at it with the lens of the data, information, knowledge, wisdom framework, which you see in the triangle here, we can say, okay, this clinical documentation support, that's really at the bottom, right? That's just like a capture of data. But we want our clinical decision support to be supporting us at this level of knowledge and wisdom. And so we just need to keep this in mind and work towards that. And so I think at least once we start to see no longer a need for CDS to really, you know, be largely focused on this documentation support, maybe that shows us that that we've improved. But certainly we want our CDS to, you know, be promoting top of license practice for all of our clinicians. So some other work that we've done focused on nursing documentation in the acute and critical care setting was simply quantifying and visualizing it. And, you know, documentation's kind of been quantified a lot of times through time-based measures, as I mentioned before. Here, we were actually looking at, you know, entry of how many data points are being entered. So just quantifying that, which had yet to be counted necessarily. And so we found that on average, nurses were documenting one data point every pretty much 1 minute in the ICU, and about the same average, one data point, you know, every 0.82 to 1.14 minutes in the acute care setting. Those averages pretty much equate because in the ICU you have fewer patients, but you document more information per patient. But, you know, we found, and you just see a visualization down here of a snapshot from one nurse's shift, that this documentation, it wasn't just that it averaged 2 every minute, but they really were consistently in the record all through that shift, as you can see, is laid out by these different timestamps across the x-axis there. And so I think it just speaks to the amount of time and quantity that we really require nurses to be in the record, as opposed to, you know, more direct patient care. A student of mine also has looked at, through some time motion studies, this notion of frequent task switching in the context of documentation burden. So you're in the record, you're entering data, then you're viewing data, then you're putting a procedure in, and then you're putting an order in, for instance, and how quickly you're switching back and forth between those activities. And overall, you know, it seemed to be that clinicians were switching between activities every, or had about one and a half switches every minute, which seems pretty high. So just another attempt to measure documentation burden there. But also from one of our studies, which is called the Concern Study, and it's funded by the National Institute for Nursing Research, we look at optional documentation that is recorded by nurses. And we look at it for the purpose of predictive modeling. We model patients at high risk of deterioration in the ICU and acute care setting. And we've been able to use nursing documentation signals in a predictive model that actually predict patient deterioration about 40 hours before leading other leading early warning scores. Why? You know, because we're using signals that the nurse is worried about the patient, as opposed to late signs of deterioration, which are in most other early warning scores, which are vital signs. So the vital signs don't change until, you know, that deterioration is occurring at that moment. But it's been shown that a nurse's concern is enough information to act for a patient and, for instance, call a rapid response. So we actually have been able to quantify that through looking at nurses' optional documentation. So when they document above and beyond when there are more vital signs documented. And this looks at the metadata, right? So we're not looking at the value of the vital sign, we're looking at the sheer presence of it and the frequency of it, as well as other things, the frequency of notes, the frequency of PRN medications. So there are a variety of features in our model. And that's not the point of this slide, but we see the value in looking at this optional documentation for documentation burden too. So what we see is that optional documentation is where the signals are, and it's the signals of nursing decision making and the nursing process, and that's where we can really find valuable information for predictive modeling, but also to understand what was done for the patient, because unfortunately, sometimes the required documentation ends up being very standard and all the same. There's no variability across different patients. And you actually do want variability across different patients in order to have information, right? And there's a notion that, a standard of care shouldn't actually have to be explicitly documented because it should just be done. We shouldn't have to ask nurses to record that they did the standard of care. So what we've found is that, like I said, that optional documentation has really important signals. And I think that this is an approach or a lens in which we can start to look at burden. Our team's starting to look at burden from that perspective, but our study really was coming from the standpoint of predictive modeling, actually, a different aim and focus, but we see the benefit combined there. We also then this past year then looked at the documentation, manual documentation entries, not things that are automatically coming from devices, but manual ones per nurse, per patient shift. We plotted them out from year over year, from this past year and then the past 3 years before that, because we knew that when the COVID pandemic hit, at least for our hospitals in the Northeast, because this includes some multi-site work, there were changes to the record for nurses. The records, EHRs were put in their disaster mode, which is essentially intended to, decrease the amount of documentation that's required. So we wanted to see what happened to the actual documentation that nurses record. Again, looking at this from the lens of, okay, all of a sudden nurses aren't required to document a bunch of information. So what did they choose to document? What was that optional documentation they chose to put in there? Interestingly, you see that red spike, and that's when we all kind of know COVID first hit, right? So that's March into April. So documentation increased. Very interesting. My take on that is there were a lot of really acute patients, and clinicians recognized we need to understand these patients, and we don't know them. We need to record this information, and that's a path to starting to understand those patients better. But then once the EHR disaster modes were put in place, kind of a month or so later, documentation didn't go below baseline. It actually just went back to baseline, where you would presumably think it would go below baseline. So again, thinking that this starts to point to the fact that nurses increase their documentation when they see the clinical need for doing so. And I think this is a good lesson to keep in mind when we think about, documentation burden and the regulations that we put on nursing and how we should actually be reflecting on their professional practice and their autonomy a bit more. So, our team has found the act of documenting a free text comment or other optional data in a flow sheet row is information the nurse likely determined an event or observation was clinically significant enough to record. So we found in our work that focusing only on the values of EHR data actually missed these healthcare processes that you can look at instead. And this approach can shift how we understand, leverage clinical observational skills and clinician-entered data to measure a variety of things, including burden. To point out really quickly, as part of this work, we did plot our predictive model against other early warning scores in the context of racial disparities. We did find that there were disparities in other early warning scores. We actually purposefully included features in our model to mitigate those racial disparities. And so that's why, you know, there aren't significant ones in our model. But I just point this out because we're talking about documentation burden, but there really is clear evidence that our EHRs, the documentation in our EHRs, have bias. They have bias along racial and ethnic lines, as well as I'm sure other categories as well. And so again, important to reflect on when we think about documentation burden and how we may intervene on it. So to kind of sum up, you know, the last few slides, you know, my team, we look at what we call healthcare process modeling, identifying features from user interaction with the clinical systems, which are patterns of clinician behavior. We then, you know, interpret those patterns as proxy of the individual's decisions, knowledge, and expertise. And you can use those patterns in predictive models for association with outcomes, importantly, including clinical domain expertise for their interpretations. But again, applying this to the concept of documentation burden in, you know, some innovative ways to think about the problem. So to finally sum up some of this work, you know, bringing it together from the symposium findings too, you know, some of the things we found, and especially within the nursing domain, talked about issues with accrediting organizations versus that we've done it to ourselves in overbuilding these EHRs. There's some lack of clarity in the rules that are put out there and different interpretations. This we've done it to ourselves might come from this gotcha mentality where we overbuild our records and have a fear of litigation and document a lot in there to kind of cover your butt and make sure it's in the record. But what are we really missing because of kind of this cycle of burden? And there are certainly many other factors into this cycle of burden, you know, usability being one, workflow being another, reimbursement being another. But we're missing in the nursing domain, at least, and I think there are parallels to other healthcare providers, but personalized nurse care planning, opportunities for higher level clinical decision-making, capture and synthesis of the patient's story, and communication of key patient information to the interdisciplinary care team. And so with that, I am going to end, and hopefully there's some time for questions. Thank you.
Great, thank you. Very, very interesting talk. I will ask the first question and actually preface it with a comment. You know, it's amazing to think that it's, you know, it's what, about 12 years since meaningful use, when we went from almost no use of EHRs to now they're being widespread, and us in the informatics community kind of bearing the brunt of people complaining about them, rightfully so. But it is, I never would have imagined we'd be talking about these sorts of things. But my question is, I certainly understand the tagline, and you've presented a great, plan for clinicians and education and policy and all that. How will you know that this, especially since we really can't measure burden precisely because there's so many measures, how will you know in a few years that this initiative has succeeded? What kinds of things would you be able to point to?
Yeah, it's a great question. So those are certainly some things that I will emphasize our weekly meetings with the steering committee are still struggling with, right? I mean, you need to measure in order to know, and we need some more and better measurements. I think that some of the measurements will have to do with engagement levels and, you know, movement in kind of that policy advocacy and vendor space. So not just, you know, measures within our EHR, but measures around different rules and so forth. And I just highlight that because more recently, in the past month or two, like, it was noted that there have been changes to some physician billing regulations, and actually they've been great. And so some of it was noted that what we're lacking now is awareness, that's awareness kind of broadly, or talked about more at scale, if you will, that really helped, and that those have been really good. And so that's one side of it, but that's kind of more the softer side. Not necessarily easier, but when it comes to measurement, perhaps a bit easier. But the dissemination's like so important, and the engagement so important. But I think some of what we say, that there needs to be engagement from national organizations and working groups around that, and engaging organizations like ONC and HL7 and so forth, that measurement needs to be a part of that. That needs to be early in the conversation. Our symposium did not solve that problem, and it needs to be front and center in how we're going to get there.
Great. Well, I think I see other people turning on their screens, so I'm just going to open up to the audience. Just speak up if you want to ask a question.
Hi, Sarah, it's Dana. So good to see you.
You
Always
too.
enjoy following your team's work and enjoyed the presentation. I had a question. Your concern project really demonstrates the value of nursing judgment in what they document, and how that, really correlated with patient outcomes. Do you think that could possibly be a strategy for reducing documentation, where I'm sure there's ethical considerations, but where you almost removed all documentation requirements and allowed them to document what, per their clinical judgment, they felt was good, and then some combination of that plus what other people review of what they document in the record could become like a new minimum standard? I just wondered about your thoughts about how we might even go about doing that type of a study.
Yeah, I love how you articulated that. I absolutely agree. We were actually hoping, and still are, and looking at it, and this is something that we are starting to study, is using COVID as a natural experiment to start to look at some of that. Because yeah, how do you actually, how do you get a hospital to all of a sudden say, okay, we'll get rid of, all the regulations we have, and you can experiment on that? That's a bit more challenging, but we actually have this opportunity with all the changes that did occur with COVID to begin to demonstrate that the value is in the optional documentation. And I think we'd have to demonstrate it pretty robustly from a few different angles to begin to make it so that hospitals felt comfortable making those changes. But I think that there's some positive from COVID, that it was recognized we need to change our systems, and so there is some opportunity there. But yeah, I think absolutely that kind of turning it on its head and saying, let's see what the nurses document, and kind of maybe looking for gaps in quality there, as opposed to building the EHR against every quality measure that we can think of.
Hi, Sarah. This is Ruth Schleier. I haven't seen you for a long time. Good to see you. I did want to just comment related to COVID, that we moved to a disaster documentation standard operating procedure during that time, and did a survey of our nursing staff afterward to get a sense of their experience with that standard. And we asked a question around whether they thought that having the standard supported their ability to document based on their professional clinical judgment. So, maybe offline, it wasn't a formal study, but, it might provide some insight, some qualitative data.
That's great.
So,
yeah,
we could
and overall, did the nurses prefer?
It was mixed.
The disaster mode. Oh,
yeah,
okay.
We had some mixed results. It revealed some cultural things that we need to pay attention to.
Interesting. Yep. Interesting.
My name is Deb Levy, and I'm a student and a clinician practicing. And I actually did not do research on it, but I was interested in reflecting on the, sorry, sore voice today, too many talking through masks and N95s last week, but the concept of complexity offsetting, and you brought that up in a couple of sections, that when the complexity went up in COVID, that nursing documentation may have increased kind of along the lines of your concern study, but with a kind of COVID slant. And I was interested in anecdotally experiencing that as a clinician and watching our documentation burden actually go up, trying to explain what we were doing with a novel condition. And so I was both fascinated, and it resonated with my experiences. I don't know what the data is, but I just think that's a incredibly powerful concept of, we were freed to write less, but could you really do it and still capture what you're trying to take care of in a novel condition?
Yeah, that's great. Thank you for sharing that. I mean, it makes me think of, you know, what we always want to say is, right, the documentation should reflect the practice, right? And not more, but not less. You know, so in my mind, as a former ICU nurse, that makes sense, and it helps the individual nurse probably, you know, or clinician process the information, because it is new information to them. I think in terms of figuring out how to care for those patients. Yeah, I think there are a lot of interesting cognitive studies that could be done around that issue too.
Thank you.
Hi, Sarah.
Oh,
How are
hey.
you? It's good to see you.
You too.
Great talk. This is fantastic. One thing that I was wondering if you could speak to a bit more, and you did touch on this, but if or to what extent you see kind of the usability of the data at the point of care factoring into this sense of burden. I have to imagine, and I've spoken to clinicians who say this, that part of what's so frustrating is not just that they spend the time documenting, but that they feel that the data are then not really actionable. Either they can't get them back out, or they can't get them out when they need to.
Yeah, absolutely. That came across very strongly in the symposium, I think through a few different factors. Like one being the notion of information overload, which you're talking about, which we didn't necessarily talk about a ton in the symposium, but it was brought up. You know, your review of the data, that can be burdensome. It's not all about data entry. But certainly it's burdensome just to try to process the information and find it. But also it came up in the sense of it just propagated double documentation, because I can't find that information, though I know it's in there. So I need to document it again just to kind of cover myself, you know, or for completeness in my note. And so it's a big cycle that occurs.
Great.
And
Thank
that was
you.
one of the reasons that I think there was a strong discussion too of the need for better team-based documentation. You know, so they tie together very closely, that I don't need to document, you know, the same thing that I know my team member did, whether they're in the same, you know, discipline as me or not. You know, we're team members, and I should be able to rely on their documentation. But if I can't find it, and it's not really set up for team-based documentation, it's not going to happen.
Great. Thank you.
Great. Maybe we can either take one last question, or otherwise we can call it a day. It's been great to see this nursing informatics reunion, Columbia reunion activity. Thank you so much, Sarah. This is a really fascinating project. I'm sure our field is going to hear a lot about this going forward. Maybe unfortunately, in the sense of we're solving a problem that our systems created. But actually, I do like what you said about, you know, these are really early days. I mean, even though EHRs have been around a while.
Yeah.
Well, good. Okay. Well, thank you again for presenting, and thanks everyone for attending, and have a great day. And those in Portland can go out and enjoy the nice weather. Okay. Take care,
Thank you so
everyone.
much.
Bye-bye.
Bye-bye.